two main categories, ulcerative colitis and Crohn's disease, and kind of what sets them apart, kind of how we can differentiate the two, because there are some minor differences in how we treat both disorders. So inflammatory bowel disease, three main topics we're going to hit. The major ones today are Crohn's and ulcerative, and then we'll hit on microscopic for just a bit. The two classic ones, though, being Crohn's and ulcerative colitis. And then the last one, microscopic colitis, is a distinct entity on its own. It doesn't present like the other two. Basically, it's watery diarrhea that's chronic in nature, but you have a normal colonoscopy, which we'll talk about. Very different findings with UC and Crohn's from microscopic colitis. So, like I said, inflammatory bowel disease, two main conditions: chronic recurrent inflammation of the GI tract. The main differences between Crohn's and ulcerative are where the disease process is located, how deep the inflammation is getting into the bowel, the different layers of the mucosa, and then the pattern of mucosal involvement, whether it be the entire colon or whether it can start hitting different areas of the colon over on the ascending, the descending, which is going to set Crohn's apart from ulcerative, because ulcerative is going to always involve the rectum and extend proximally, whereas Crohn's can be anywhere in the GI tract. It's patchy and it's transmural, and we'll get into each one in the next few slides. So just a picture for the visual folks. As you can see, Crohn's popping up red there in different areas of the large bowel, whereas ulcerative always starting at rectum and then moving proximally. There's also extraintestinal manifestations of IBD. There's a big list for you, but I'll touch on the main complications throughout the lecture that I want you to be aware of. Be familiar with the list, but I want to talk some specifics that happen with ulcerative versus Crohn's and vice versa. So Crohn's, transmural inflammation. So it's the entire thickness of the bowel wall. That's what transmural inflammation means. The entire thickness of the bowel wall, which is different in Crohn's than ulcerative. Crohn's can affect any part of the GI tract. Mouth to anus is what we say, anywhere in the GI tract. Most commonly, it's going to be in the terminal ileum. Most common site, but it can be anywhere, mouth to anus. Crohn's can lead to ulcerations, stricturings, fistulations, and abscesses. And the extraintestinal manifestations that I showed you, the large slide which encompasses all of IBD, you're going to see them more commonly in Crohn's than you are in UC. It can be mild all the way to fulminant disease. Worse in smokers. So hallmark of Crohn's, skip lesions. So little areas of patchy inflammation, and then another area of patchy inflammation, then another area of patchy inflammation. When you're looking at it under scope, as you can see, just in that limited view that's on your slide there, you can see inflammation in a little spot, and a little bit longer area of inflammation, but there's normal mucosa in between those lesions. So we say patchy skip lesions. So basically, inflammation areas separated by normal tissue. Here's a helpful mnemonic for you all to remember Crohn's. So 2 C's for the mnemonic. Crohn's crawls everywhere. Like I said, anywhere mouth to anus. Cobblestone appearance. Those are little patches, like little discrete areas of inflammation. Usually right lower quadrant pain. Can lead to obstruction. It has holes or fistulas, which we'll define in further slides and give you some examples. And it's usually non-bloody diarrhea. So this acronym will capture most of the landmark features you're going to see on your boards and on tests. Is if they're describing an inflammatory bowel disease and it has these characteristics of Crohn's, the acronym, that's what you're looking at, versus ulcerative, which we'll discuss in depth just a bit later in the lecture. As I mentioned, both of the IBDs present with intermittent symptoms over a long period of time, which can lead to fatigue, weight loss, chronic diarrhea, and abdominal pain. Usually the diarrhea with Crohn's, non-bloody. And where do we say the abdominal pain would be? Right lower quadrant, usually. So it waxes and wanes. Highly variable presentation because, as I said, it can be anywhere in the GI tract. Most commonly, terminal ileum. So you get that right lower quadrant pain, intermittent non-bloody diarrhea, and weight loss. Bless you.
Thank you.
So just a reiteration of this on this slide of what I just told you. Because it's normally in the terminal ileum, that's why you have right lower quadrant. And then the other associated symptoms there. And remember, non-bloody. So some of those complications can lead to fibrotic strictures, which narrows the inside of the lumen of the GI tract. So you can get an obstruction from Crohn's. So how will that present? It'll be postprandial bloating, crampy abdominal pain. You'll have those borborygmi, the loud bowel sounds. So kind of vague, right? Kind of vague. But you can get intestinal obstructions, and when you do, you start getting the bloating after you eat, then crampy abdominal pain, and those loud abdominal sounds. Because Crohn's is transmural, but completely through the mucosa of the bowel, it can penetrate completely through the bowel wall, which is going to give us a lot of these classic complications that I discussed on the Crohn's acronym. So you can get an abscess, you can get sinus tracts, and then eventually those sinus tracts can connect with the external skin or other organs, and we call those a fistula. Mainly with Crohn's versus ulcerative. And there's a picture on the slide to show you how you get tracking, and then once those tracts connect to the external skin, and then we'll talk about some other organs that those tracts can connect and make basically a long opening line between other organs or the external skin, then we call it a fistula. So there is an error on this slide. I just noticed it actually. We've talked about a phlegmon. Does a phlegmon have a wall or not? It does not. So make sure you correct that on these slides. So it's an expansing area of infection. It should not be walled off. It is not walled off. Versus an abscess, which is a focal area that is walled off. Because you can get penetration through the entire bowel, you can also get the abscesses anywhere in the abdomen, which is going to give you fever, abdominal pain, and tenderness. Basically, peritonitis signs and symptoms. Like I said, make sure you correct on your slide, and I'll put a correction up on Blackboard as well, or on Canvas as well, to put the definition of the phlegmon, although we're all pretty familiar with it at this point, but it is not walled off. So then the fistula, one of the complications of Crohn's, abnormal connection between the two epithelial surfaces. They can go to the bladder, skin, sometimes a small bowel, and also into enterovaginal, so vagina. And there's the common locations on the slide and then how we describe them based on what other organ that those sinus tracts penetrate, thus becoming a fistula, communicating with those other organs. So the symptoms, basically, from the fistulas are gonna depend on where that fistula is actually communicating to. So if it's intravesical, you can get chronic UTIs. You can also get some air in the urine, pneumaturia. If it's intercutaneous, you're gonna actually have bowel contents that are gonna drain to the surface of the skin. And then for enteric, could be asymptomatic, or you could have a mass when it starts to go into the small intestine. And then intravaginal passage of gas or feces through the vagina, because there's a tract going from the large bowel to the other organs. If it's a retroperitoneal fistula, you can actually get psoas, abscesses, or urinary obstruction and hydronephrosis. So know the complications of the fistulas from Crohn's and the organs that the large bowel is connecting with through a fistula. A lot of perianal manifestations, so a lot of the things that we discussed in last block, we're going to get skin tags, fissures, abscesses, and fistulas. And I just talked about what they were, and you should remember skin tags from when we talked about anal rectal disease. Where are the anal fissures in Crohn's? You took a test on it. They're lateral, and they're not in that posterior location where we see 90%, right? So we've already passed the test on it, so this should be a review. That the Crohn's anal fissures are lateral in location. Extraintestinal manifestations, as I said, they're all on that chart that I mentioned earlier in the lecture, but you can get arthralgias and arthritis, iritis or uveitis, so inflammation of the eye, the uveitis being the middle layer of the eye. You can get erythema nodosum and pyoderma granulosa. Basically, there's some pictures coming up of those two, but they're kind of not really pathognomonic, but highly likely that it's Crohn's when you start seeing those painful red to purple lumps, erythema nodosum, usually on the lower extremities, and then the pyoderma granulosa, which are painful sores and ulcerations, also a lot of times on the lower extremities. You can get oral aphthous ulcers with Crohn's, and there's a picture on the slide showing you an ulcer of the upper lip, inside of the upper lip. We also can have an increased prevalence of gallstones as a complication from Crohn's because malabsorption of bile salts from the terminal ileum can lead to increased gallstones. And just remember when you're linking it all together, which extraintestinal manifestations go with which disease under IBD. So there's the pyoderma granulosum, the ulcerations, and then those painful nodules, erythema nodosum. So how do we work it up? There's not a single lab test to say, oh, this is Crohn's, right? But we talked about nutritional deficiencies, and we can also get some anemia. If there's an infection or an abscess, we can get high white count or leukocytosis. We can also look for those elevated inflammatory markers that we talked about in block 1. Fecal calprotectin, which just says there's inflammation in the GI tract, not specific for Crohn's. Our signs of inflammation, ESR and C-reactive protein can be elevated. And we can also get some iron and B12 changes, nutritional deficiencies. So nothing specific to say this is Crohn's. The only way to say it's Crohn's is to get eyes on the objective, right? Get the scope. So the workup to establish a diagnosis, endoscopy, right? In this case, colonoscopy. Colonoscopy, gold standard. So we're going to see all of the manifestations that we just discussed, with your Crohn's acronyms, right? We're gonna see that cobblestoning, ulcerations, skip lesions, because we're gonna have areas of inflammation, normal tissue. As we travel with the endoscope through the bowel, we're gonna see, okay, there's disease or inflamed areas, and okay, that's normal. So that's that cobblestoning or skip lesions. If there's any upper GI complaints, not only will we go down up, but we'll go up down with an upper EGD. If needed, if there's any of those restrictions or blockages, we might have to do the capsule endoscopy, case by case determination on the capsule. But endoscopy is gold standard. Minimal probably colonoscopy, but possibly EGD. Sometimes we'll actually go to the CT or MR to show the evaluation of the small bowel, but the gold standard will always be done, the endoscopy. Graded on severity scale. So the Crohn's disease activity index, that's the CDIA. Basically, the clinician goes in and grade it based on how bad the signs and symptoms are. Asymptomatic remission, meaning you're not having any signs and symptoms, but you have the disease. Then mild to moderate, and there's a scoring system there for you where it falls. You do not need to know the scoring system. If we ask about Crohn's, it's going to be giving you signs and symptoms and severity, not the CDAI score, but just so that you're aware, if you do have a patient diagnosed with Crohn's, there's a scoring system that the patient will go in and fill out. I think it might be the next slide. And then we put them into one of those categories as the disease progresses from asymptomatic all the way to severe fulminant disease. And there's just a screenshot of the calculator, and we're just, based on signs and symptoms, we're going in and checking boxes, and then there's a score at the end that'll put in one of the categories from the previous slide. Crohn's disease activity index. So the American Gastroenterological Association also further stratifies risk as either low, moderate, or high for Crohn's, and that's basically looking at the inflammatory status. So they do the endoscope, either a colonoscopy or a colonoscopy and an upper EGD, and they look for the ulcerations and stricturing and how much of the GI tract is actually involved, so the extent of involvement. And then they do some of those inflammatory markers to track, so the C-reactive protein and or the fecal calprotectin elevation. And then also they assess a higher risk if it's actually in the upper GI tract versus just the lower GI tract. So just another way to categorize Crohn's based on symptoms and then risk by the American Gastroenterological Association. So the treatment, we treat those extraintestinal manifestations such as the abscesses, any obstructions, those fistulas. That's usually going to require a surgeon consulted to fix the holes, right? To surgically repair either the obstruction or the fistula or the sinus tracts that are developed, or drain any abscesses may have formed. Mainly, we treat the symptoms, generalized symptom control first, and that's the goal of there is just improving the quality of life of these patients with this chronic waxing and waning disease process. And then we're going to talk about reducing the progression of the disease and then trying to reduce the complications. We'll get, and obviously lifestyle changes, thus the big no smoking. So there's no cure, so it's important to discuss with your patient. There's no lifelong cure. So expectation management is to try to achieve remission through induction and then prevent reoccurrence or complications through maintenance. So we're going to try to induce remission through induction, then maintain remission and prevent complications. And there are categories on the bottom of the slide there for Crohn's. We're going to treat their symptoms, and then we're going to give them some medications for the active disease, and then we're going to talk about maintenance therapy if the medications for active disease helped or didn't help. And so we'll get into the eaches of the medication treatments. Next slides. So if they have diarrhea, we give them antidiarrheals. Loperamide your first line, and then you can also move towards bile acid sequestrants if there is significant involvement of the terminal ileum, right? So where we absorb a lot of nutrients. So those bile acid sequestrants kind of reduce the LDL from the blood. If you remember, the main drugs in that class are the choleostrepine, cholestyramine, cloverislam. So just know that bile acid sequestrants, second line antidiarrheal if you have terminal ileum involvement. Oral steroids, so what we're going to put on those aphthous ulcers. And there's your example, Kenalog and Orabase. So triamcinolone oral prep. You have to be specific, when you're ordering it to make sure you're getting the topical triamcinolone for those very, very painful aphthous ulcers that the patients with Crohn's develop. So now we move into treatment for low risk or mild Crohn's. So in this category, really no or mild symptoms. C-reactive protein and fecal calprotectin levels are normal or mildly elevated. Usually the diagnosis is over 30 years of age. So it's kind of late onset Crohn's, over 30 years. Limited in its distribution of bowel. Superficial or no ulceration when they do the colonoscopy. There's no perianal complications, which we talked about those. And no prior intestinal surgeries or resections. And we don't have penetrating or restricting disease. So that's our mild patient with CD. So how do we treat it? For mild, to induce remission, we begin with budesonide, corticosteroid. 50 to 70% of our patients with mild CD are going to achieve remission. You're going to induce remission with budesonide, and that's oral budesonide, which will come into play when we start talking about ulcerative colitis. So that's oral budesonide, and if they fail budesonide for terminal ileum, ascending colon, induction, then we'll move on to prednisone, if they don't respond and have more systemic effects. But budesonide is your first line. Occasionally, we'll use 5-ASA, mesalamine or sulfazine, in our CD patients with mild disease. There's limited clinical data on the 5-ASAs for Crohn's, which is the exact opposite for ulcerative. So just remember that the 5-ASAs are limited clinical data in Crohn's. Occasionally, we still will use them. So mild Crohn's for induction, if it's diffuse or mainly left side, we'll go right to the prednisone, skip the budesonide. And then the sulfasalazine is an alternative agent. Less effective in inducing remission than the prednisone. Once again, we're just talking about induction. And we were talking the difference between diffuse and then the right side. So if we get induction, then we move to maintenance therapy for Crohn's. If your patient achieves remissions with the budesonide or the prednisone, then we don't do any pharmacological maintenance. We just monitor for reoccurrence. How do we do that? With those inflammatory markers, C-reactive protein, inflammatory bowel marker, fecal calprotectin, or we do an endoscopy every 1 to 2 years. If it was in the large intestine, no upper involvement, then we'll just look at the colonoscopy for the monitoring. if it involved upper GI. It's probably not mild, but if it was, then we would look at an upper EGD as well as colonoscopy. If our patients are achieve remission with the 5-ASA, then we do keep that for long term, and then 6 months to a year, we scope them again. So if, the take-home point here is if you had induction of remission with the steroids, then we're just going to monitor. If we had to put it on 5-ASA, then we're going to keep them on long-term 5-ASA, and then we're going to follow up with a scope in 6 to 12 months. High-risk Crohn's, those are the folks that get it earlier, under 30 years of age. They have a history of active or recent tobacco use. So those protein levels are elevated versus mild. We said mildly elevated or normal. And then they have the deeper ulcers on colonoscopy, which we didn't see in our mild disease. And it's long segments of the small or large bowel are involved. They also now, for the high risk category, start to have some of those perianal complications that we discussed. And then they have some of the extraintestinal manifestations, those aphthous ulcers or those skin lesions. And if your patient has had, if your patient has had a past bowel resection for any reason. Now we're in the high risk Crohn's. So how do we treat these moderate to severe? To induce first, we're going to start with corticosteroids again. Budesonide if it's just isolated to the ileitis, or prednisone to alleviate symptoms. These are going to be short bridges. And then we move into a new class for moderate to severe. Now we look at biologic anti-TNF medications, which you should be vaguely familiar with from last semester. Plus an immunomodulator. So if we get to the combo therapy, if we get to the past the corticosteroids, which for moderate and severe, we're just using those corticosteroids as a bridge to get them on biological agents, those anti-TNF agents listed there, and we're also going to put on immunomodulators. So azathioprine, AZA, or the 6-mercaptopurine, or methotrexate. And if your patients are on the combo therapy, they obviously have immunosuppression. So maintenance, that was induction for your moderate Crohn's, and now we're going to maintain it. So we're going to basically look at just preventing relapse with maintenance. And how do we do it? They stay on immunomodulators or biologics. Usually the anti-TNFs, 1 to 2 years for maintenance therapy, trying to prevent relapse. And if your patient stops responding to the anti-TNFs, we can switch to a different med in that same class. Or we can switch classes between the two that we discussed on the last slide. So you induced, went into remission, prevent relapse for your moderate category is continue that anti-TNF for 1 to 2 years. And if they stop responding or start showing more signs and symptoms, we can switch between the drugs on the last slide. Within the class or from the other class. We talked about surgery. When are we going to need it? Well, obstructions, abscesses, fistulas, or severe refractory disease. So if we start having those perianal or enterocutaneous fistulas or obstructions, as I mentioned, it's time to get the surgeon on board. Fix the holes that the Crohn's is caused by going completely through all layers of mucosa of the bowel. Who do you admit? Sick patients, right? Severe dehydration. If they have an obstruction, you're going to admit them. If they have the abscess, or if they just in general have severe symptoms. So if you start thinking there's an abscess, either intra-abdominal or perirectal, they're getting admitted. So your patients, as I mentioned, that are on the anti-TNFs or the immunomodulators, they're immunocompromised. Right? It lowers their immunity. They're at high risk for infection. So usually those patients, if they're taking the steroids and on either of those immunomodulators, then they're going to be admitted because they're going to have serious infection complications. If the diarrhea or the weight loss or abdominal pain is very severe, we'll admit those patients too. And if they have severe symptoms despite the steroids, we're going to admit them. Always want to get nutrition on board with your IBD patients. As I mentioned, GI, obviously they're the specialist in disease involving the intestines, and then surgery, if any of those complications, whether they be extraintestinal or within the abdomen, and if surgery is required, then we'll obviously need consult surgery to plug the holes. And then there's also the Crohn and Colitis Foundation of America, which can give you a lot of support and information for the patients and the provider. So that brings us up to the other major player in IBD, ulcerative. Go ahead.
Sir, I might have missed this, but is this more of a genetic thing, or is this more like predisposed if you get exposed to something, I don't know,
Unknown, autoimmune, inflammatory disorder. I mean, they've looked at a lot of different angles. It's unknown as to why patients have it. There's no genetic marker for it, so to speak. It's for whatever reason, predisposition, folks develop it, and it's autoimmune, but no known other than the risk factors I gave you. But it's not like your BRCA1 or BRCA2, like a gene mutation that you can track and say, oh, you're going to be at higher risk. Obviously, if you have other autoimmune disorders, you're probably at higher risk. All right, so UC. So this one is limited to the mucosal layer. That's your first big difference between UC and Crohn's. That's why you don't have as many those abscesses and fistulas and sinus tracts, because it's just the mucosal layer. It doesn't go through all layers of the bowel. About a quarter are in the rectosigmoid region. We term that proctosigmoiditis. About half extend up to the splenic flexure. You should know where that is. So that's left-sided colitis. And then a quarter more extend proximally, and that's extensive colitis. As I said, from the anus to the mouth. So anywhere in that tract. Sorry, I just said anus to the mouth. That was Crohn's. Now we're talking just UC. So defined by where in the colon that the inflammation is. So proctitis, proctosigmitis, distal colitis, pancolitis, the entire bowel, and then the extensive colitis not involving the ascending colon. Characterized by exacerbations and periods of remission. So waxing and waning again, just like Crohn's. Ranges from mild colitis to fulminant colitis. Significant risks of toxic megacolon. We talked about toxic megacolon on Friday. So this is one of your big players that can cause it. Extraintestinal manifestations are similar to Crohn's, but significantly fewer UC patients are going to develop fistula. Unlike Crohn's, where most develop fistula. Interestingly enough, UC patients who smoke, severity is lower. I don't think I would advise my IBD patients that have UC to go out and start smoking. However, the severity is lower in active smokers, and their severity can actually worsen if they are a chronic smoker and abruptly stop. So very different from Crohn's, but still, I guess you'll have to take that one on a case by case. I can't see recommending someone not to quit smoking, but that's what the data shows. So UC characterized by universal involvement of the rectum and the sigmoid colon with continuous erythema and ulceration of the mucosal surfaces. So it's continuous, no patchy areas of inflammation like we saw in Crohn's. It's continuous, anus up, ascending. The major differentiator between your Crohn's and ulcerative is that continuous pattern. Approximately. Hallmark is bloody diarrhea. What did we say about Crohn's? Non-bloody. Another big differentiator. Usually non-bloody. But with UC, bloody diarrhea with urgency and tenesmus. What is tenesmus? You feel like you still gotta go, right? You chronically feel like you gotta go, then you just went. So there's your differentiators for how the patient's presenting, how we categorize them, mild, moderate, and severe. And basically it's based on their symptoms and then their stool frequency, if they're having any weight loss, and then their hematocrit, their temperature, and then those inflammatory markers, ESR, and then their protein, albumin. Just remember, bloody is a hallmark difference for ulcerative. Mild to moderate disease for UC, we're going to say gradual onset of diarrhea with blood and mucus. They have that urgency and they have tenesmus. Usually left lower quadrant pain. Different from Crohn's, which is right lower quadrant usually because of where it's usually at in the terminal ileum. With our UC mild to moderate, a lot of times that left lower quadrant pain is going to be relieved when they defecate. Moving into the severe side, now we're just having more bloody bowel movements, more than 6 a day. They can start showing signs of hypovolemia with 6 bloody stools a day. Anemia because of the amount of blood loss. Hypoalbuminemia, so decreased protein. And the left lower quadrant pain is still there, and often they will have tenderness on palpation on exam. And for the severe disease, the left lower quadrant pain is not relieved by defecation. So know the difference between UC mild to mod and severe. How do we work them up? Well, the same way that we did for our Crohn's, just a general workup, CBC, CMP, get the protein in the blood, those inflammatory markers, the fecal calprotectin, the GI-specific inflammatory marker. We can do a stool culture and an O&P. Why? Because it's some type of inflammatory diarrhea, because there's blood in it, so we need to rule out that there isn't some other cause, which we discussed last walk, that's causing their bloody diarrhea. We also talked about bloody diarrhea so the need for the O&P, remember those are the eggs or the actual bugs themselves when we talk parasites, and then we need to do STI testing. So you're ruling out that something else isn't going on. And then normal inflammation workup. Just like Crohn's, the workup includes an endoscopy. That's how you're going to get the diagnosis. You have to confirm with getting your eyes on the objective. In acute disease, we're not going to do a full colonoscopy. We're probably just going to do a flex sig. We're not going to put them through the entire bowel prep, and we're probably not going to want to run the colonoscopy through the entire large bowel. The reasoning is also to avoid a perforation, as it says on your slide, because severe UC can lead to toxic megacolon. We don't want to cause that. As your patient responds to treatment, then we'll get a colonoscopy, a full colonoscopy down the line. So the biopsy, when you're in there with the colonoscopy or the flex sig, we're going to take a culture, right? We're gonna take a specimen and we're gonna put it under biopsy, look under the microscope, and then the biopsy findings are gonna show crypt abscesses and crypt branching, and you're gonna see some atrophy of the crypts. So you're gonna possibly have mucosal distortion basically on biopsy. And we talk about crypt abscesses. What do the crypts do? What do the anal crypts do? They basically just help lubricate the anal canal, right? So when we're looking at those glands in the crypt abscesses, you're gonna see usually inflammation or some branching of them and shortening and atrophy of those lubricators of the anal canal, basically. Treatment, similar to Crohn's. We're going to treat the acute active disease, and then we're going to try to get them into remission and maintain it and prevent recurrence. Treatment can differentiate like Crohn's based on severity. So once again, we try to through induction, induce remission, and then maintain it. Main difference you need to be aware of is the last bullet on that slide. That the 5 ASAs are the mainstay. Remember when we were talking about induction for our Crohn's patients that are rarely used, that classifications, the mesalamines. So the 5 ASAs are the mainstay in UC, unlike in Crohn's. This is an excerpt there for the ulcerative colitis. This is their clinical practice guidelines. It just basically tells you once you confirm it, how do you confirm it? How do you confirm it? Eyes on the objective, right? Endoscopy. Usually in flex sig or colonoscopy, at least further down the road if they can't take the colonoscopy or the risk is high early on. But the key point to address is it distal, limited below the descending colon, so that you can get topical therapy to it. So this is going to be a big difference, so you have to determine if you can actually use topical therapy or if it has to be systemic oral therapy. So if it's proximal to the descending colon, so anything above the descending colon or proximal to the descending colon over into the transverse colon, then we're going to have to use systematic drugs. If it's below the descending colon or below, then we can often use topicals, usually in the form of suppository. So very important when that endoscopy is being done, whether it's the flex sig or the colonoscopy, to determine the margin of that inflammation to know if it can be treated with topical agents or if it has to be treated with systemics. Mild to moderate distal colitis, so just the distal colon, confined to the rectosigmoid colon. Topical mesalamine. 5-ASA topical with a suppository. And you've got your common trade names there off to the right, but you just need to know that if it's rectosigmoid colon only, mild to moderate, we're going to do topical suppository 5-ASA. First line. Mesalamine is the one that you'll normally see. Other treatments, we can add on hydrocortisone suppositories or enemas. And we're still in that mild to moderate distal colitis. And if it's more not responding or patients just won't use a suppository, then we can give them the mesalamine orally or the sulfasaline. Normally it's going to be mesalamine. So if they refuse to take the suppository, we move to orals. Still mild to moderate, and it's distal colitis. We're going to do co-therapy with oral and topical 5-ASA. Also add a topical steroid, glucocorticoid, to the topical mesalamine. And then we can also add oral prednisone. So that's your step-ups. If the patient's not responding, if it's limited to the distal colon, refractory to the other methods, now we go from the bottom, or we go and systemic, and then we add a topical glucocorticoid to the topical 5-ASA, and then we can add oral prednisone. So if it's mild to moderate but extensive, so it's extending proximal to the sigmoid colon, we're going to do the oral and the topical 5-ASAs. The reason you're going to see the mesalamine more than the other medications right there on your slide is because of the side effect profile. And you have to give folic acid if you're going to go the sulfasalazine. 2 to 4 weeks, if the oral 5-ASAs aren't working, then we're going to add the topical corticosteroids. So start for mild to moderate, proximal to the sigmoid, oral and topical, so meaning rectal suppository 5-ASA, normally mesalamine, and then if that isn't cutting it, we can add a topical corticosteroid with the 5-ASA suppository. Maintenance, so whichever medication we had to use to induce remission, we got them in remission, and then if they responded to the topical 5-ASA, we're going to do it every night. And for those who require the combination with an oral 5-ASA, then we're going to keep them on it as well. Extensive, that's mild to moderate, oral corticosteroids, and then we move into the class that we use for the Crohn's, the immunomodulators and the anti-TNF agents, and other biologics there at the bottom. So remember that any of those biologics are going to decrease your immunity. And we move into that class for mild to moderate and it's extensive colitis. Severe or fulminant colitis, so pancolitis or fulminant disease, they're going in the hospital. Get the surgeon on the phone and start giving them bowel rest, nothing by mouth, replacing fluids, and often IV corticosteroids. Key here, severe or fulminant, early surgical consult because we could be leading to a toxic megacolon. Absolute surgical indications, severe hemorrhage, perf, or carcinoma, cancer. Those are your absolute surgical indications. I would know this slide. Your relative or severe colitis unresponsive to maximum medical therapy, which we just talked through. And then if we have less severe colitis but medically intractable symptoms, or they can't tolerate medications. Those would be relative surgical indications. As I said, consults, GI, and if needed, surgery. If they get to fulminant, they're going to need surgery. And we talked about the patients to admit, frequent bloody stools, anemia, weight loss, fever, so systemic symptoms, or worsening symptoms. And then your fulminant disease is rapid progression, worsening abdominal pain, distension, very high fever, and tachycardia. So your patient's getting septic. And this is a good time to take 10 minutes, and we'll finish up microscopic after.
telling you. We're not going.
Feels like we didn't step up.
This is what my paper's on.
Oh, that's fine, we're waiting for Sam to come back.
Yeah.
Dang. Whose house is
Yeah, that should be.
it? I don't know if you were seeing from hurricanes, tornadoes, connectors. The Warriors. Oh yeah. Well, you make it on Twitter. Yeah. Oh my God. I won't even sleep this time here. I don't The thing is, yes, yes,
It's really moderate. I don't, when I tested it, one end of full moon $1,000.
Oh, that's what you want? You can recoup from tutors. That's not bad. It's not cool. It sounds good. I can't Greek mythologist. I don't think it was mythology for that. Did he actually believe that stuff back then? Look, you just got out of the shower. I mean, I think that's just really, it's funny.
I'm supposed to do 30 minutes on, 30 minutes off, but I keep forgetting and just keep going for hours. I'm like, oh, I need to stand up.
She's at 3 minutes.
Set a timer and like enter a class. Like, no, I gotta stand, sorry. Fuck you. This one. Right after, I think that's yeah.
Especially if the program is back.
You see that happens with
I would probably do this.
this right here. I mean, I really just
That's pretty stressful.
we didn't pass.
All right, we set. So just a point of clarification here, on UC, my slide number on this one is 53. But when we're talking about mild or moderate extensive treatment, we said if it's extensive colitis extending approximately to the sigmoid, it's the oral and topical 5-ASAs. And then we can add the topical steroids if there's no improvement in 2 to 4 weeks. So then if we move forward 2 slides here, so there's UC maintenance. Now when we get into UC treatment, it says mild to moderate extensive colitis there. Scratch out the mild, we'll just call this moderate. This is if the mild to moderate we talked about 2 slides ago, the symptoms persist. So we'll say now we're moving more into moderate to severe. Then we can add those oral corticosteroids, and then we start talking about the immunomodulators and the anti-TNF agents. So it's mild to moderate. We try the 2 different ways, the 5-ASAs, so we can add that second treatment. If symptoms persist, now we're going to say moderate with extensive colitis. Now we can move into oral corticosteroids, and then the immunomodulators and the anti-TNF agents or the other biologicals. And then step next would be severe or fulminant colitis. So if you want to just cross out mild on that last slide, or you can just know that it's mild to moderate and patients still have symptoms besides after you give them those first level, line 1, line 2 medications. So now we're more moderate, so symptoms are persisting, then we can move to what I just showed you on the last slide there. So we'll call that more moderate. I can tell you when I test it, when we start talking about mild to moderate, moderate, severe, it's probably going to be mostly on the extremes, right? We're going to be able to say, okay, this is fulminant severe disease, or this is mild, that's how we treat it. When we start talking moderate, it's hard to kind of test your knowledge on that because it can be signs of mild, but some severe. So usually it's going to be pretty apparent if your patient has a fulminant disease or if they're on the mild end of that spectrum. We clear on that, everybody good with that one? Okay. So 1 second here, get back to microscopic. Microscopic colitis. So it's still in the category of IBD. But this one, as I mentioned at the beginning of the lecture, now we're characterizing this by chronic watery diarrhea, but you've got a normal colonoscopy. We talked about diarrhea in Crohn's versus ulcerative, and now chronic watery is very different with microscopic colitis, and then you don't see any lesions when you do the colonoscopy. So you get normal appearing mucosa. So you don't see skip lesions, you don't see anything we talked about with Crohn's, and you don't see anything associated with ulcerative. Basically, it's diagnosed with a microscope. They have to look at histopathological examination of the specimen taken during a colonoscopy and look at it under a microscope and goes, yes, this is microscopic colitis, so therefore it's easy to remember the name because you can only diagnose it by looking with a microscope.
So I'm just curious, IBSD, is this IBSD with the
Well, remember, you're normally going to be bloody on one end, but it can be watery, but this is diffuse water. It's always watery. No mucus, no blood. It's chronic watery diarrhea. So every time you go, it's chronic watery. And so probably going to try to rule out all the other causes of diarrhea first. This isn't going to come to your mind. It's not as prevalent as the other two. And it's when we talk about watery diarrheas, it's usually not first on your list, right? You're going to probably do a full workup and have nothing until we go to, after trying all of our first line, second lines for watery diarrhea. Then we'll get that probably a colonoscopy or a sigmoid. We'll take a slice, send it off to the lab, and then they'll go, oh yeah, this is consistent with microscopic. So it's not usually what you're going to be like first line hunting for. So it's usually a diagnosis of exclusion, and then you have to confirm with the microscopic or histopathological exam. Most common is in elderly women and medications. There's your list of medications. Those aren't exactly, 100%. Yes, these do it. These are your biggest suspects for causing microscopic colitis. So microscopic changes to the colon. So the NSAIDs being a big one, and then there's some specifics there from a few different classes. So be familiar at least with the top 2 or 3 there. Clinical presentation, chronic, non-bloody, very watery. 4 and 9 watery stools per day. So it's going to present, as he asked, it's going to present differently than your Crohn's patient, and definitely different from your UC patient. 4 to 9 watery stools a day. Abdominal pain, and obviously losing that much fluid, they're going to have some signs and symptoms of hypovolemia. Fatigue, dehydration, weight loss. Diagnosis, routine labs, we're trying to find if there's something else causing this. And then a clinical suspicion, we can't figure anything else out, so we do a scope, and then we get the biopsy, and then the microscope folks say, yes, it's microscopic colitis. Treatment, well, if it's a med that's causing it, we think we stop that med. And then we give it some antidiarrheals if needed. If the diarrhea persists, sometimes we go to the budesonide oral for a few weeks. So for IBD, patients that have long-standing IBD, increased risk of colorectal cancer. It's obvious when we talk about all the signs and symptoms and those changes that are happening in the mucosa, that we're getting some dysplastic cells, but there is an increased risk of colorectal cancer for any patient with any of the 3 forms of IBD. If your patient has a diagnosis of IBD, 8 to 10 years after that diagnosis, they need a screening colonoscopy. I would know those numbers. 8 to 10 years after the diagnosis of IBD, you need a colonoscopy. And then a screening every 1 to 5 years. So 8 to 10, initial diagnosis. After that first colonoscopy, every 1 to 5 years. Based on your risk factors, if there's other colorectal risk factors, which we'll discuss here in just a couple of minutes, then that might lead us more towards the 1 or 2 or 3 or 5. But 5 is the maximum number of years between the colonoscopies with the IBD patient after their initial one. And so for IBD, we're to your memory jog, and give me just a second, and we're going to move on to polyps and cancer. Pretty short lecture, so I think we'll get through that today. And the goal is to try to get all your lectures done for this block by Friday, because we won't meet again until a week from this Wednesday, and that should be our review, and then you test the Monday after that. So the goal is, and I'll get all the other lectures hung tonight for the rest of the week. I was trying to do your memory jogs, some of the last couple of those, because some folks have mentioned they like having them at the end of the lecture. Those last couple I might just hang where I'm putting the check on learnings. Your check on learnings from Friday are there. So that's the goal, just so everybody's tracking, is to get through all lectures by Friday. A week from Wednesday, do a review, and then you guys can come in and max out this test a week from this coming Monday. All right, moving right into colonic polyps and colorectal cancer. So extremely important clinically, right? Because most colorectal cancers develop over long periods of time. So we gotta talk about screening and how we can get after identifying folks at risk, because normally there's polyps that form, and certain types of polyps, specifically adenomatous polyps, over long periods of time developed into colon cancer. And so if we can get our patients informed, talk to them about risk factors, get colorectal screening, the earlier that we can identify the disease process, the more likely we are to prevent it and or to catch it early and not have it progress in severity and cause more and more problems, ultimately possibly leading to death. So what is a colonic polyp? A polyp is a discrete growth of tissue, basically just projecting inward from the lumen of the colon. So when we talked about diverticulosis, which way does the diverticular go? Out, right? So it's that bubble blowing out on the outside of the lumen. But with polyps, it's on the inside. So you have to put your eyes on the objective to see polyps. So most polyps, sporadic and asymptomatic, meaning we are doing a screening for something else and we see them. However, some polyps, depending on location, can bleed. They can cause a rectal bleed. They can cause that lower abdominal cramping and feeling like you've got to defecate but can't, tenesmus. And some polyps can be large enough and depending on location can actually cause an obstruction of the GI tract. So we can classify them when we look at them on endoscopy by size. Those are the three different ones: diminutive, less than 5 millimeters, small, 6 to 9, and then your large, anything bigger than 10 millimeters. And we also categorize them by morphology, whether they're depressed or flat. Depressed meaning they actually go into the mucosa a bit. Flat, obviously being flat with the edge of the tissue of the mucosa. And then we have sessile. Sessile polyps are elevated and they're attached by a base. They're elevated and they also can be attached by a base. And then we have pedunculated, which are elevated but they're attached by a stalk, i.e. they have a stalk leading to the lumen and they're out on top of that stalk. The pedunculated type, when we're doing endoscopy, it's much easier to actually remove the pedunculated because they're on the stalk that the gastroenterologist can just pull out when they're doing the scope. So here's just an example of flat, sessile, and pedunculated, and showing you kind of how they look on endoscope. We have, I think, some actual scope pictures of them here. Yeah, so there's your pedunculated on the stalk. Sessiles, you know, it's kind of flat. It's attached, but it's flat and broad. Like I said, you can see why it's easier to remove the pedunculated polyp. Four major pathological groups. Number one is the most common to lead to cancer: adenomatous polyps. And we have mucosal serrated, mucosal non-neoplastic. So obviously if it's a non-neoplastic, less likely to lead to cancer. And then we have submucosal lesions. So the key takeaway from these four categories is that the adenomatous polyps, we consider those precancerous until proven otherwise. Number one there, the adenomatous polyps, precancerous until proven otherwise. Not that any of the others can't lead to cancer, but the adenomatous category most likely to. So adenomatous polyps, most common, neoplastic. So those are the most common ones that can lead to cancer. They're pre-malignant because over time, those are the ones that lead to slow growth turning into cancer. Serrated polyps have a soft tube pattern on the crypts, but that's once again looking at under microscope, so that's a histological exam. Many of the different polyps, like the serrated, are benign, hyperplastic. If you say hyperplastic, less concerning. for precancerous. When you see dysplastic, or adenomatous, that's when we start worrying. By definition, adenomatous or dysplastic. But some of your serrated lesions do have a malignant potential, just not nearly as many as the adenomatous. And the serrated often include your hyperplastic. So the non-neoplastic polyps include mucosal, non-neoplastic. A lot of times these will be your hamartomas, which is your second bullet underneath your mucosal non-neoplastic. Hamartomas, they're benign tumor-like malformations made up of abnormal mixture of cells and tissue found in the regions where they grow. So they're benign gross, but it's normal tissue. They're just arranged a little abnormally, but they are not dysplastic. And then the submucosal lesions is another non-neoplastic, which creates a polypoid appearance of the overlying mucosa. Yeah, the so what on that is if you see adenomatous or adenoma, dysplasia or dysplastic on a histological exam, that's bad. That's more than likely cancerous. Not so bad, hyperplastic or hyperplasia. Because when you see adenomatous or dysplastic, dysplasia, that's pre-malignant changes. The hyperplastic, on the other hand, generally low risk for cancer. So if you see either of those two bullets or hyphens under the top bullet there, that's when we start getting concerned. We also have some hereditary disorders that cause polyps. So these are polyposis syndromes. What we're looking at there on that slide is familial adenomatous polyposis, so FAP. It's inherited, hundreds to thousands of polyps. Usually these develop early, by like the age of 15, so early teenagers. And these patients diagnosed with familial adenomatous polyposis, they will have colon cancer. They will have colon cancer. It's usually inevitable, typically by 40 or 50 years old. These patients, by that age, develop colon cancer. And a lot of times, this diagnosis, the familial adenomatous polyposis, they're going to usually have a prophylactic total colectomy, sometimes before the age of 20, or else they will develop colon cancer, colorectal cancer. Now we talked about your screening for your patients with IBD. Well, if a patient has this disorder, they have an annual colonoscopy starting in adolescence. Annual colonoscopy, like I said, usually by a pretty young adult, they're going to get a total colectomy, prophylactically, to keep the cancer from developing and possibly metastasizing to other organs or areas of the body. Here's another polyposis syndrome. That's hamartomas polyposis syndrome, Peutz-Jeghers syndrome. You're going to have those hamartomas in the GI tract, and you also have these oral lesions. So dark blue or brown mucocutaneous hyperpigmentations, as you're seeing on the slide there, with hamartosis polyps in the GI tract. Another disease process, hereditary, under the hamartomas polyposis syndromes is familial juvenile polyposis, and these folks are increased risk of colon cancer as well. And then the third disease process under hamartomas polyposis is Cowden. Rare genetic disorder, once again, hamartomas, that's why they're in this category, and they also have risk for numerous other cancers. Solitary hamartomas polyps are not inherently malignant, as we mentioned when we We talked about the different etiologies of the categories. But those that have the polyposis syndromes, their risks are increased of cancer. But a single hamartomatous polyp, not so concerning. Only if they have one of these syndromes. So we worry more about developing colorectal cancer. So we also have a hereditary condition called hereditary non-polyposis colon cancer, HNPCC, aka Lynch syndrome. It's inherited once again, and it's associated with early rectal cancer. So all of these syndromes have, the same thing in common, is they usually lead to colorectal cancer. In the case of Lynch syndrome, it's an autosomal dominant condition, and they have an increased risk of cancer for multiple cancers. You see the list there. And there's a special criteria called the Bethesda criteria used for screening the risk of those other organ cancers for patients who have Lynch syndrome. You don't need to know it, just know that it exists. The Bethesda criteria for screening your hereditary non-polyposis colon cancer patients, aka Lynch syndrome. Bethesda criteria. So on the colorectal cancer, risk factors, 90% are folks 50 and older. If you have a personal history of polyps, multiple, or those that are villous, or greater than 1 centimeters, or you have a history of dysplasia, like I said, the term dysplasia, usually bad on a histology report. If you have a personal history of any type of cancer, primary or recurrence or mets, you're at a higher risk for colorectal cancer, or your patient is. Personal history of IBD, higher risk. And the risk is then extrapolated based on the severity of your IBD and how long you've had it and what part of the bowel it's in, or of the intestines. Family history of colorectal cancer, if someone that's a first-degree relative had a cancer at a young age, or you have multiple first-degree relatives that had a colorectal cancer, your patient is at a higher risk. If you have any of the inherited syndromes we just discussed, we talked about having a higher risk. That's the acronyms for them there. The BRCA1 and 2, those are genetic mutations that we can screen for. When those genes are suppressed, they can lead to breast, ovarian, and other type cancers. We're not going to really get more into the BRCA1, 2 because that's more in a different lecture. But any of the GI inherited syndromes or the polyposis syndromes we talked about do increase your risk, as I said. Unclear if inherited risk of colorectal cancer is tied to ethnicity, or if it's due to underutilization of actually getting the recommended screenings and the recommended ages, which we'll touch on here in a sec. Lifestyle can increase your risk of colorectal cancer. Smoking, obesity, sedentary, diabetes, obviously, high fat, and low fiber diet. So your big players for any cancer are listed there in the lifestyle. Clinical presentation for colorectal cancer. Most are asymptomatic. That's why we have to educate our patients to get the screenings. Because most colorectal cancer patients are asymptomatic. If you see microcytic anemia in a man of any age, or a postmenopausal woman, that is cancer until proven otherwise. And we'll hit that a little bit in the last block. Microcytic anemia in a postmenopausal woman or a male of any age, you've got to start looking from below up and up down to figure out if it's cancer, because it is until proven otherwise. New onset microcytic anemia, iron deficiency. Other common presenting symptoms for colorectal cancer: abdominal pain and cramping, change in bowel habits, or the caliber of stool. A lot of times your patients, if they have a mass, they're going to have a narrowing of the stool because there's a space-occupying lesion inside the lumen of the GI tract or the colon. Particularly if that's right-sided, will they have the bowel habit change and the caliber change, i.e. now we got constipation or diarrhea, or we have narrowing of the stool. Rectal bleeding, dark stools, blood in the stool, obviously of concern for your patient. They will come in and say they have those symptoms, and that's when you're going to do your fecal occult or refer them out for a colonoscopy. Weakness and fatigue, and unintentional weight loss, which by now we should all know unintentional weight loss kind of goes hands in hand with worrisome or alarm symptoms that patients present with. We have to put cancer on our radar. Other signs and symptoms depend on the location. So if it's the right side of the colon, normally that's what's going to give us that iron deficiency anemia and the weakness and fatigue. However, it's on the left, we start seeing more changes in bowel habits. The stool can be streaked with blood because obviously that's lower down in the GI tract, closer to the rectum. So if there's a mass or cancer there and it's a bloody lesion, obviously we can see streaks of blood on the stool because the stool is not traveling as far into the GI tract when it's close to that mass in the lower GI on the left side of the colon. Obstructive symptoms happen more on the left side, i.e. constipation, alternating with diarrhea or stool frequency, loose stool, and we get some crampy or colicky abdominal pain, those waves of cramps and pain, i.e. there's something occupying space in the lower colon, and so our body is going to try to push out peristalsis. So as we try to force the products of digestion and stool down through the GI tract, if it's on the left side, lower in the colon, then our body's going to continue to rhythmically spasm and try to cause peristalsis past the lesion. That's why you get the colicky abdominal pain if you're masked in the left colon. If it's rectum proper, well, blood in the stool. Once again, tenesmus, you gotta go. I feel like I had the urge, but I can't go. Or urgency, they have to go and be close to a toilet because they don't get much of a time warning where they feel they have to go and they gotta go immediately. And we also get classically decreasing the caliber of the stool if it's in the rectum, called a ribbon stool. So it's just not well formed, it's just long, skinny like a ribbon. Signs of advanced metastatic cancer, complete obstruction. You need to know apple core. You've probably already seen it on x-ray, in your x-ray class, I'm not sure, but if not, we'll give you a refresher. But a complete obstruction, sign of advanced metastatic disease, is an apple core lesion. Weight loss, fever, chills, night sweats, all signs of advanced disease. Or that the tumor is now moved out of the colorectal area and metastasized to other areas of your body. So, colorectal cancer screening evaluation, colonoscopy, test of choice, colonoscopy. Gold standards, because you can visualize and you can take a biopsy. A lot of times our physical exam is going to be unremarkable. You may have the anemia, if you pull the CBC, you could have weight loss, you could have palpable, abdominal, and rectal masses for large masses. You must do a DRE for your CRC screening. When you do the DRE, you can do like the fecal occult test, which is great, but if you get a positive fecal occult or any of the other fecal tests that we're going to talk about, three main categories, if they're positive, you still got to get a colonoscopy. You should do the DRE, you should do the Guaiac test. However, if it's positive, it's colonoscopy. Because for colorectal cancer screening, colonoscopy is the test of choice, because not only can you see what's going on, you can also take a biopsy and look at it under a microscope. Initially, for our colorectal cancer screening, non-specific labs are normal players, right? CBC, CBP, and iron panel. We're looking for that iron deficiency anemia. That's what IDA is there. And then colonoscopy study of choice, indicated for both screening and diagnosis, because we can get a biopsy and send it down to be looked at under a microscope. Here's that pathognomonic finding of the apple core lesion. So basically, it's a constricting mass, constricting mass. So we've got the lumen of the bowel shrunken down to about a fifth or less of what it should be because of a constricting mass. And you can see the picture there, why we call it the apple core lesion. Colorectal cancer path in mind, apple core lesion. Here's some on CT, positive arrow signs, show you where you're looking. And once again, same presentation of the apple core lesion, colorectal cancer. Slow growing over many years, that's why screening is so effective. If we can identify those adenomatous polyps, we can prevent them from turning cancerous, possibly. So you may have that polyp for years before you have any symptoms, but if we follow routine screening guidelines, we can identify it with a colonoscopy, we see it, we can take the little biopsy, get folks to look at it under the microscope and then say, oh yes, this is adenomatous and it already has some dysplasia, so then we can get after that with the surgeon and get it removed early before they start having symptoms. Normally, if you have colorectal cancer and you're having any of the symptoms we discussed, that you're already well down the path. Usually very poor prognosis if you're having symptoms as to why you're getting this colonoscopy to look for colorectal cancer. This slide basically says average risk adult, 45 years of age, start screening. 76 to 85, dealer's choice, right? The evidence is some say yes, some say no. So that's the discussion with your patient. Okay, how often have you had any colorectal cancer screening between 45 and 76? Were there any abnormal findings? Otherwise, the data really shows not so great above 76 as to predicting and getting after preventing colorectal cancer once patients are at that age. But that's a discussion. I think the next slide talks about it. That's a discussion to have with the patient based on their history, based on other comorbidities, their if any level of colorectal screenings they've had in the past. But right now, average risk starts age 45 with a colonoscopy. It used to be higher. It's been lowered in the last few years. Average risk asymptomatic individuals 45 to 75 get a colonoscopy. As I mentioned, 76 to 85, no real net benefit of screening everyone in that age category. Consider their overall health, like I said, comorbidities, what, if any, past colonoscopy screenings they've had, and talk to the patient about their personal preference in that age group. Gold standard colonoscopy every 10 years. There's a lot of other tests that can be done, but what you need to know is start at 45, the gold standard is a colonoscopy every 10 years. There are options, right? CT colonography, FlexSig, the fecal immunochemical testing, which is under that stool-based test. So there's some different timelines. If you're doing visualization-based tests, the CT colonograph would be every 5, FlexSig every 5, or every 10 if you're doing the FIT test, which is a stool-based test, the fecal immunochemical test, which you have to have annually if that's what you're relying on. And then the high-sensitivity guaiac fecal occult blood test, that's annually. And then the FIT DNA, that's your Cologuard, that's every 1 to 3 years. But then the gold standard is colonoscopy every 10 years. Any positive finding on anything other than colonoscopy, you get a colonoscopy. So it's good that if you're part of your annual exam, you're getting the fecal DRE, and they're doing the guaiac annually, but if that ever comes back positive, it's time for a colonoscopy. Get the gold standard. These are the stool-based tests. We've talked about guaiac. The hemocult, it can be done there in the office. DRE, you wipe it on the sample card, you hit it with the guaiac chemical. If it turns purple, blue, it's positive. The fecal immunochemical test, that looks at the hemoglobin antibodies to detect blood in the stool. It's more sensitive than the guaiac-based fecal cult blood test. The FIT is more sensitive than the guaiac test. And then the FIT DNA test, Cologuard, detects altered DNA sequence, so it's looking at actual cancer cells in your stool. So it's more sensitive than the FIT above it, but it's less specific. More sensitive for DNA cancer cells, but less specific than the FIT. And as I mentioned, any of those, most of them are annually, it's required if that's what you're using for your screening. I think the Cologuard's 1 to 3 years, but if any of those fecal screening tools are positive, colonoscopy time. So high-risk patients are, as I mentioned, a family history of colorectal cancer. Any first-degree relative less than 60, or greater than or equal to 2 first-degree relatives, regardless of their age. If your patient's family history includes those, they're higher risk. So what does that mean? Or if they have any genetic syndromes, they're going to get earlier, more frequent screening. So if your patient has that family history, then we move it to 40 versus 45, or 10 years younger than the youngest age first-degree relative that had a cancer diagnosis, whichever one's earlier. So I would know that statement in bold on that slide. So if you have family history, one of those 2 hyphens under family history of CRC, then your screening colonoscopy is going to start at 40 or 10 years younger than that first degree, those first degree relatives that had cancer, whichever one of those 2 is earlier. If your patient has IBD, you're going to do a colonoscopy with biopsy every 8 years at the onset of symptoms, followed by a colonoscopy every 1 to 2 years, which is the exact same metrics we talked about in the last lecture. 8 to 10 years from diagnosis, get a colonoscopy, and then every 1 to 2 years from there. The HNPCC we discussed, remember it happens in our younger population, annual colonoscopy screening at 25. That was the hereditary non-polyp colon cancer, Lynch syndrome. So annual, starting at 25 every year. And then the familial adenomyosis polyposis patients, even younger, inevitable to get cancer, they start at 10 to 12 years old. I would know pretty much this slide. So colorectal cancer screening, carcinoembryogenic antigen, not a screening test. It's useful for prognosis after your patient's been diagnosed with colorectal cancer. So it's basically used as a tumor marker after you've been diagnosed with cancer to mark for reoccurrence after you've had treatment. Monitoring for colorectal cancer, not screening. So this, the slide should probably be changed. The heading. It's not a screening test. So tumor marker for monitoring reoccurrence. Treatment, well, you're definitely going to refer this out to a specialist, right? Oncology and surgery. Your patient, depending on where the cancer is located, how large the mass may be, may or may not be, that's how they're going to determine how much of the bowel has to come out. But patients with colorectal cancer usually get some, most, or all of the colon removed. They also undergo chemotherapy normally and radiotherapy for rectal cancers. Prognosis, this is why screening is so important. If you catch it in stage 1, 90% chance. 90% survival rate. Stage 2, a little less, still pretty good, 70, 85%. Now if we get into stage 3, and now we got some mets into some lymph nodes, we're down to 67%. And progressing on, if we're at stage 3 and you got more than 4 positive lymph nodes for cancer, now we're down to a third percent chance of survival. And in stage 4, it's 5 to 7%. It's worse if you catch it later. So that's why screening and patient education is so important. And that will be the final thought. And your check-on learnings are posted with this lecture already, and the other ones I'll